Okay, we're going to talk about the diseases that affect endocrine system within certain animals. We're going to be focusing mainly on the dog and the cat, but we'll touch a couple of other species as well. So we have to remember about the endocrine system. The cells of the body have to maintain homeostasis, or this equilibrium, with their internal environment, because the chemical processes that are conducted at the cellular level can only occur under specific conditions. The endocrine system is going to work together with the nervous system to achieve a stable internal environment. Each system may work independently, or the systems may act together to accomplish this task. The hypothalamus, part of the brain, nervous system, and the pituitary gland, part of the endocrine system, regulate the release of chemical messengers called hormones. These are chemicals that are secreted directly into the bloodstream to signal target cells and to perform certain functions in response to changes in homeostasis. As hormone concentrations in the blood increase, the system is signaled to reduce hormone production. This is your negative feedback system, which works much the same way as a thermostat controls the heating system in your home. The glands that regulate the release and balance of hormones work continuously to maintain homeostasis. When one or more of these glands work ineffectively, incorrectly, or even not at all, a potential for problems develops. The endocrine glands most commonly involved in diseases of small animals are the thyroid gland, the adrenal gland, the pancreas, the parathyroid gland, and the gonads. Diseases that affect the pituitary gland or the hypothalamus cause multiple irregularities in the body, because that is the nerve and endocrine control center. And there are a lot of hormones that come from that area. Let's go back to this kind of chart picture of the cat and showing where these glands are. The pineal gland is further back in the head than the pituitary gland. The parathyroid gland is a small nodule, which is on top of the thyroid gland or within the thyroid gland. We have the adrenal gland that's on top of the kidney. Now, the kidney does produce hormones as well, but we're not going to worry about that quite as much in this lecture. The ovary and the testes, depending on if it's a female or a male, and then the pancreas. Let's start with the thyroid gland. The thyroid gland is located in the ventral cervical region along the lateral margins of the trachea. So if you point to the juncture between your the back of your chin, the underside of your throat, and where it meets your trachea, that's right about where the thyroid gland sits on either side of the trachea. Usually it's not palpable in a healthy animal. You should not be able to feel this. But if you have a gland that is hyperactive and producing more hormone, typically will get bigger, and you'll be able to feel alongside the thyroid, and you'll feel a little blip slide under your thumb and forefinger. The gland is composed of follicles that produce the thyroid hormones T3 and T4. Triiodothyronine, which just means 3 iodines connected to the thyrine molecule, and then tetraiodothyronine, which is 4 molecules of iodine connected to the thyroid molecule. These hormones are produced by the follicular cells and stored in the gland until they're needed by the body. There's a third hormone called calcitonin that's also produced by the parafollicular cells, not within the follicles, but around the follicles in the thyroid gland. And calcitonin acts to decrease calcium deposition within bone, to decrease blood calcium concentration. And T3 and T4 function to control all of the body's metabolic processes. So remember, calcitonin decreases hypercalcemia. And we're going to talk about parathormone, which is nearby the thyroid gland, works to prevent hypocalcemia. So they work kind of against each other. So here's a picture of the thyroid gland, and there can be 1 or 2 parathyroid on each thyroid gland. That's where the parathormone comes from. The thyroid gland, what are the hormones? T3, T4, calcitonin. 2 common diseases of small animals involve the thyroid gland. There's hypothyroidism, which means we have insufficient thyroid hormone, and hyperthyroidism, which means we have excessive thyroid hormone. Hypothyroidism is most commonly seen in the canine, 1 out of 156 to 500 animals, so it's fairly common. Hyperthyroidism is seen primarily in the cat. Now, I don't have numbers on that, but it's actually a fairly high percentage of older cats have hyperthyroidism. Hypothyroid disease is there are two different types. There's the primary acquired hypothyroidism. It's the most common type of hypothyroid disease in the dog, and it usually follows thyroid atrophy or a lymphocytic thyroiditis, so an inflammation of the gland, the thyroid gland. So we either have the thyroid gland is atrophying or it is inflamed and causing a decrease in T3 and T4 production. Centrally acquired hypothyroidism is rare and develops when we have a problem with pituitary or hypothalamus. Clinical signs: breeds that are predisposed to this disease are Golden Retrievers, Dobermans, Irish Setters, Schnauzers, Cocker Spaniels, and Dachshunds. It's common in middle-aged dogs, 4 to 10 years of age, and we usually see it more in female versus male dogs. So 2.5 to 1, we'll see it in female dogs. There will be a weight gain with no change in diet. So all of a sudden they're getting a cup of food twice a day, and all of a sudden we're starting to see them just balloon out. There may be some bilaterally symmetric alopecia, which means we have hair loss on either side evenly. Rat tail, which means they're losing hair on the tail, kind of looks like a rat. We need to understand that hypothyroid disease and Cushing disease are the only known diseases that produce that alopecic pattern. So we have hypothyroid disease and Cushing's disease have that bilateral symmetric alopecia on either side of the body and a rat tail. We'll also see, because the thyroid gland monitor or regulates metabolism, when we have a decrease in metabolism, that means that the skin cells are not being produced normally, that the organs are not being regenerated normally. We have dry hair, excessive shedding, we have lethargy, we have anestrus or infertility or testicular atrophy. Basically, their reproductive system won't work. There may be hyperpigmentation of the skin, which means it's darker than normal. They'll be intolerant to cold. Remember, I said that the thyroid gland helps to generate heat when we have the animal is cold. So the metabolic reactions generate heat. And if we don't have that, then they cannot tolerate cold. Anemia and hypercholesterolemia are also signs of hypothyroid disease. 66 to 75% of these animals will have an increased cholesterol level. Now, typically this won't cause the same problems that we'll see in humans. It doesn't cause blockage of arteries, but it is a significant finding. 25 to 40% of these animals will have a mild non-regenerative anemia. That means the bone marrow has not been stimulated to produce more red blood cells. We, in order to diagnose this, will perform a radioimmunoassay. It's just a blood test. It tests for T3 and T4, and we should see a normal T4 concentration of 1 to 4 micrograms per deciliter. There are in-house tests that help us to test for T4, but we have to remember that sometimes we'll have a low T4 and the body, and it's just a normal part of the hormonal regulation of the body. Sometimes we'll have a low T4 if the animal is otherwise ill. That's called sick euthyroid syndrome. So we have to kind of look at the values that we're seeing and look at the rest of the signs that we're seeing in the body. We can do a thyroid stimulating hormone test or a TSH test. They are kind of more expensive, and we have to actually send that out to a lab. When we do a blood test and they're already on medications, we are looking for a peak response. So we're looking, when we supplement the thyroid, the T4 for the animal, because they're producing a fewer amount of it or less amount of it, we are going to want to give them a pill and then take a blood sample at 6 hours. That will give us our peak concentration. And if we're getting a peak concentration of T4 greater than 2 micrograms per deciliter above the baseline concentration that we have, then we are going to be concerned about hyperthyroidism, which is an increase in the metabolic rate and can also be a problem. So we need to, when we are supplementing these dogs, we need to make sure that we're maintaining it at a level that's not going to make them go the other direction. When we are measuring and diagnosing this disease, it is important to get a couple of different tests because this thyroid hormone is very complex, and the way that the T3 and the T4 or T3 is used and T4 is made into T3 and the thyroid stimulating hormone interact, all of that together make it very confusing and complex and difficult to really diagnose this problem. So there is actually a test called a free T4 by equilibrium dialysis, which is important to do when we're first trying to diagnose this disease. If they have a low free T4 by equilibrium dialysis, or ED, then we know that they are truly hypothyroid. If they don't have a low free T4, then they may be just sick and having a low T4 level in the blood, which we can test normally. So there are also antibodies that the animal will create toward the thyroid hormone, and if they have too many antibodies to thyroid hormone, they can actually, in a way, it's its own body attacking the thyroid hormone. And so if we have a high level of thyroid hormone antibody concentration, that means that it's not able to perform the function. So there are a lot of different things that go into thyroid disease. Primarily what I need you to remember is that it can be caused by a number of different things. Either we don't have enough thyroid stimulating hormone, we don't have enough production of T4 or T3, or we have too much thyroid hormone antibody, which is attacking our T3, our active thyroid hormone, and not allowing it to do its function. So a free T4 by equilibrium dialysis with a TSH monitoring and a thyroid hormone antibody concentration level will give us a much more complete picture of what's actually happening in the body. If they have hypothyroid disease, it requires lifelong supplementation with thyroid replacement. Dogs, we usually use trade name products like Saloxin or levothyroxine. I'm sorry, Saloxin is a trade name product for the active ingredient, which is levothyroxine. And we dose it at 0.1 milligrams per 4.5 kilograms twice a day. So what that means actually is that if we have an 80-pound dog, they will get about 0.8 milligrams. And then we have to reevaluate in about 4 to 8 weeks when we have a good level within the blood. We want to see what their clinical response is, and we want to measure the actual level of thyroid hormone in the blood at 6 hours post-dose. And that will tell us, do we need to adjust that dose? And then we want to measure them every 6 months or so to make sure we're on the right dose. Some dogs need less, some dogs need a little bit more than what the typical dog will need. What you will need to remember in this is that most people receive a high dose is 0.1 milligrams. So when they see you giving their dog 0.8 milligrams and their dog is obviously significantly smaller than they are, this is going to create a little bit of anxiety. So you want to explain that they get a different dose. Cats, if they do have hypothyroid disease, would get 0.05 to 0.1 mg daily, and then we reevaluate them 4 to 6 weeks and adjust the dose as needed. Oral supplementation, you've got to tell the client for the life of the animal, usually twice a day, and they're just going to need to keep renewing the prescription. Daily dosing is required to maintain normal concentration of thyroid hormone. Remember, we're trying to take the place of a normal body function. Excess medication can produce signs of hyperthyroidism. So remember, with endocrine disease, anytime we're supplementing with a normal hormone, we can cause the opposite effects of that disease because it's all related to negative feedback system. Okay, so we're going to see if we give too much medication, they're going to get hyperthyroidism. Those signs are increased thirst and urination, nervousness, weight loss, excessive panting, weakness, and increased appetite. And if they see any of those signs, they need to stop the medication and call you. Follow-up blood tests not may be required, but will be required to ensure adequate hormone concentration. And certain drugs can decrease thyroid hormone concentration. So we need to be able to make sure that we know what this animal is currently on so that we can watch what else we put them on. So cortisone, aspirin, flunixine, meglumine, which is Banamine, it's an anti-inflammatory, furosemide or Lasix is a diuretic, and phenobarbital. So if they're on a thyroid medication, we're going to have to really watch when we put them on something else. Now, hyperthyroid disease is most commonly seen endocrine disorder in cats. However, it is rarely seen in the dogs. But if it is seen in dogs, it's a result of cancer. I have seen it in a couple of dogs, once in a Schnauzer, once in a Parsons Russell Terrier, but it's really, really rare. The disease was first documented in the late 70s to early 1980s, and it's been increasing steadily. We're seeing more and more of this disease in cats. There is an excess of both T3 and T4 results. T4 when you measure it in the blood, and it results in a multisystemic disease that's seen primarily in older cats. There's a bilateral thyroid gland enlargement in about 70% of the cases, and that's a result of a functional thyroid adenoma, or a tumor of the thyroid. What I have here, I have blips here, and that's because you can actually feel it blip past your fingers as you feel the trachea. So normally as you run your fingers on either side of the trachea of a cat, it should be, you'll feel the ridges of the trachea, but it should be relatively smooth all the way down. If your thumb and forefinger go out a little bit and then back in, you've run into a thyroid blip. Thyroid carcinoma is rarely seen in the cat, so it's usually a benign growth. 1 to 2% of the cases of hyperthyroidism is actually caused by a malignant growth in the thyroid. We see it in middle-aged to older cats. They'll have weight loss even though they're on their normal ration or even more than their normal ration. They'll want to eat more. It's polyphagia. They're trying to feed that metabolic process because it's really increased. There may be vomiting, increased appetite, tachycardia with or without murmurs. So the heart rate will start beating much faster. They'll become usually much more aggressive. They'll you'll feel that thyroid. They'll have an increased systolic blood pressure, and occasionally, because we have that increased blood pressure, it'll actually blow out the retina of their eyes, and so they'll have sudden blindness. A lot of times, these are older cats, super skinny. They're not grooming very well, and they're wandering around the house meowing loudly for food. And that's how people will describe it to you. And it'll be all night long, so they'll bring their cats in to you pretty quickly. We are going to check for that palpable enlarged thyroid and look for increased serum T4 concentration. Now, this is a disease that we can diagnose in-house if you have the thyroid hormone test on your chemical analyzer. Some other things that we will see is sometimes an increased alanine aminotransferase, which is ALT, alkaline phosphatase, which is ALP, and or LDH levels. If we see increased blood urea nitrogen, BUN, and creatinine level, that is a big red flag for us. Because what the thyroid disease does is increase metabolism and increase blood flow, which actually makes the kidneys healthier. These older kidneys that are starting to not work as well, now the blood is being pushed through the kidneys at a much faster rate, and the kidneys are actually doing a better job. It's basically a diuresis, a kidney dialysis machine that's happening. If we see increased BUN and creatinine levels, that means that even though we've got kidney dialysis going on, we still have increased levels of kidney toxins that are not being filtered out. What we'll find is very often, even when we have normal kidney levels, when we first test them, as we treat the thyroid disease, those kidney levels will increase. And now we have to deal with thyroid disease and kidney failure. Some other things that we'll see is often we'll see a high PCV or packed cell volume, and then a stress leukogram. This is a very stressful disease for them, so we'll see an increase in leukocytes as well. We can do a test by labeling iodine with 131 and injecting it into the cat, and then taking a picture. It's a radionuclide uptake imaging, and it will show that this iodine is being basically taken directly to the thyroid gland and shows enlarged thyroid glands. And so that's one way to diagnose it, and there's a way to treat it that way as well. So the treatment is the control of excessive excretion of thyroid hormones, and it can be accomplished by 3 methods. There's 4 methods now. The choice of treatment depends on the severity of the disease, the age and physical status of the cat, and what's available within the facility. So we can remove the thyroid gland with surgery, and that provides a cure for the disease, but you have to preserve the parathyroid glands so that you don't have problems with hypocalcemia. And you also may need to supplement this cat for the remainder of its life with thyroid hormone because they'll become hypothyroid. Radioactive iodine 131 is the treatment of choice. Because the thyroid gland is really the only place in the body that takes up iodine, that labeled radioactive 131 iodine is taken directly to the thyroid gland and destroys the tissue, which reduces the thyroid hormone concentration. Now, cats that need to remain hospitalized until their wastes, especially their urine, are below hazardous radiation levels. So they check them with a Geiger counter, and it can be from anywhere from 3 days to 3 weeks. So I have 1 to 3 weeks, but I've heard of cats being released within 3 days. And that takes a specialized facility in order to provide that treatment. OSU does do that. There's anti-thyroid drug therapy. Anti-thyroid drugs inhibit the synthesis of thyroid hormone by disrupting the incorporation of iodine. The drug of choice is methimazole, which is the trade name is Tapazole, and we can administer that daily. We adjust the dose every 2 to 3 weeks by monitoring the T4 concentration. Obviously, we don't want to make them hypothyroid. We want to gradually increase the dose if we're not getting the desired effect. Now, while we're checking those T4 concentrations, remember we also have to check those kidney concentrations, the toxins that are normally taken out by the kidney. If we're starting to see an increase in those, we may have to let them be a little bit hyperthyroid and walk a really fine line in order to keep them healthy. There is a 4th treatment that is now available. It's Hill's prescription YD, and it's a food. It has to be fed as the sole nutrition. Nothing else can be fed but this food. What it does is it limits or eliminates excess thyroid hormone by limiting the intake of dietary iodine. So it also helps to maintain and slows possible kidney disease. So these animals who have been, these cats that are hyperthyroid, that have been put on YD food, even if they have secondary kidney disease, they will actually get better or at least maintain their prognosis for a longer period of time on this food. So it's actually a really good option. Surgery or radioactive iodine is the only cure for hyperthyroid disease, so removing or destroying the thyroid tissue. We used to not know the cause of this disease. We just saw increased incidence and didn't know where this was coming from. But we now know that there are environmental causes for this disease, and cats are very susceptible to environmental causes because they groom themselves. So they're in contact with lots of the environment within your house or outside, and then they groom themselves, so they ingest a lot of this material. So something like bisphenol acetate or BPA selectively blocks certain receptors so that the negative feedback system is shut down. BPA is found in plastics and in drywall compound. So plastics, we've heard a lot of bad things about plastics. Well, it's true, and cats are the first incidence of certain diseases that we're seeing come from plastics and the breakdown of plastics. And so we need to remember that as we have our cats within our environment. If we can reduce the plastics, reduce the dust and the drywall compound around them, we will reduce the incidence of the thyroid disease. Medical management can produce side effects in many cats, so anything that they see should be reported to the veterinarian. Treatment to decrease thyroid hormone concentration can unmask concurrent diseases such as renal failure, and that's really important. That's why it's in bold. Renal disease can also be life-threatening if we don't recognize it. That's why in order to maintain this cat properly, we need to not only test the thyroid levels, but also the kidney levels. Concurrent disease may need to be corrected before surgery. Bilateral removal of the thyroid glands may result in hypothyroidism, which will again require daily treatment. And all animals with hyperthyroid disease should have their blood pressure checked routinely. If Tapazole does not reduce the blood pressure, if reducing the thyroid hormone does not reduce blood pressure, then other antihypertensive agents should be added. Parathyroid disease, we don't see this a lot, but we do see it occasionally. These are two glands associated with each thyroid lobe, and they secrete parathyroid hormone, which controls serum calcium concentrations. It stimulates bone resorption and renal calcium reabsorption and mediates intestinal calcium absorption. So parathyroid recognizes when we have low calcium levels, and it calls in calcium from every place that it can, from the bone, from the kidneys, and from the intestines. Typically, primary hyperparathyroidism, or something that is caused by disease of the gland, is diagnosed in older dogs, 7 to 11 years of age, and it's not usually diagnosed in cats. Keeshonds or Keeshanden appear to be overrepresented in studies of this disease, but we also see it in German Shepherds, Poodles, Retrievers, and Dobermans. There is no sex predilection, so it could affect males and females equally. Hypercalcemia results from the excessive secretion of PTH because it's gathering all that calcium from the bones, from the kidneys, and from the intestines. And it's caused by the presence of a parathyroid adenoma or carcinoma, so a neoplasia or cancer of that parathyroid gland. The disease can also be evident if the parathyroid gland is hyperplastic, so it's not cancerous, it just is producing more cells abnormally. Many animals will show no clinical signs of primary hyperparathyroidism, and hypercalcemia will be diagnosed on a routine serum chemistry examination. Signs usually don't appear until we start to get organ dysfunction, and then it can be almost too late. So what we'll see is anorexia, vomiting, constipation, polyuria, polydipsia, which is increased urination because they're drinking a lot more, listlessness, obtundation, which means they are not really aware of their environment, and or coma. Urinary calculi or cystitis, or both, because calcium is being deposited in the bloodstream and then gets into the urine through the kidney, and so it forms into crystals, and then the crystals form into stones. We may see incontinence, weakness, and exercise intolerance. Diagnosis is through serum chemistries. Low to normal phosphorus concentrations will be seen. BUN and creatinine concentration may be normal unless we have renal involvement. We have calcification within the kidneys. Serum alkaline phosphatase, so that's ALP or SAP. It's it's written both ways. May be mildly increased, and alkaline phosphatase is an enzyme that is released by damaged tissue. So it can be kind of vague sign that we have damaged tissue somewhere in the body. Hypercalcemia is the hallmark of the parathyroid disease. Serum total calcium levels will be greater than 12 milligrams per deciliter. But there are other causes for hypercalcemia, so we need to rule out other causes before we make a diagnosis of parathyroid disease. Some other causes could be that there's a sample error. Acidosis, metabolic acidosis can cause hypercalcemia. Neoplasia or cancer somewhere in the body, usually lymphosarcoma, can cause hypercalcemia. Addison's disease, rodenticide toxicosis, acute renal failure, and septic bone disease. So we need to do a parathyroid hormone 2 site assay, which means they will have excessive concentrations of serum parathyroid hormone, and we need to evaluate that in conjunction with serum calcium levels. For you to know, if calcium levels are increased, parathyroid hormone levels should be decreased because there is a negative feedback system. If we want to be suspicious if we have normal PTH levels, but we have increased calcium levels. That's indicating that the parathyroid hormone is not responding to the calcium levels. Cervical ultrasonography depends on if we can get an experienced and skilled ultrasonographer, because these are really tiny organs. If we're going to see them, if they're large enough to be visualized, they'll be 4 to 6 millimeters, which is pretty small when you're looking at, through an ultrasound. Treatment is the surgical removal of the affected parathyroid glands. We could also do ultrasound guided heat or chemical ablation of the parathyroid mass. Post-operatively, most of the time, when we have a decrease in PTH levels, we will predispose these animals to hypocalcemia. Remember, PTH levels normally respond to hypocalcemia. If we decrease the PTH levels, then they may get hypocalcemia and their body may not be able to adjust to it. We need to measure these calcium concentrations daily for 5 to 7 days, so we can keep the animals hospitalized in order to do that. Post-surgical hypocalcemia is more likely in dogs whose pre-surgical calcium levels were greater than 14 milligrams per deciliter. These animals should receive vitamin D and or calcium therapy, so they need their milk. Okay, from the time that they are recovering from surgery. Postoperatively, clinical signs of hypocalcemia include panting, muscle tremors, leg cramping, pain, ataxia, stiff gait, facial rubbing, biting of the feet, focal or generalized seizures. Calcium therapy can be maintained with calcium carbonate tablets, calcium gluconate tablets, calcium gluconate syrup. Basically antacid tablets would be helpful. And also vitamin D therapy, we have vitamin D2 capsules, calcitriol, which is vitamin D3 capsules. So we have a couple forms of vitamin D we can give them. Clients need to know that most animals diagnosed with primary hyperparathyroidism show no clinical signs. Because hyperparathyroidism is often diagnosed on routine serum chemistry evaluation, it's important to remember that we want to get lab profiles yearly for all older animals, even if it's just so that we can get a baseline. We know how they're doing. Prognosis for primary hyperparathyroidism is dependent on the severity of any secondary changes induced by increased calcium levels. And once we take care of this issue, treatment with vitamin D and calcium will be lifelong. It cannot be discontinued. Hypocalcemia, hypoparathyroidism. There are numerous causes of hypocalcemia in dog and cat. Parathyroid-related disease, chronic renal failure, acute pancreatitis, puerperal tetany or eclampsia. Those are among the most common causes of hypocalcemia. Therapy for hypocalcemia resulting from parathyroid-related disease or chronic and acute renal failure or acute pancreatitis includes correction of the underlying cause, plus vitamin D and calcium supplementation. The most common cause of hypocalcemia related to the parathyroid gland involves inadvertent surgical removal of the glands when we do a thyroidectomy or other neck surgery. It's an uncommon disorder in the dog and the cat to occur without any surgery. So we would know when we're causing parathyroid-related disease. Chronic and acute renal failure is extremely common disorder in dogs and cats, and it does represent a more common explanation for mild to moderate hypocalcemia. It's usually related to the metabolic acidosis that develops with renal failure. Acute pancreatitis, the reason we get hypocalcemia with this, is that there is a precipitation of calcium soaps when we have the pancreatic enzymes destroying the pancreatic tissue. And that precipitation of the calcium soaps on the pancreas, that tells us why we have development of mild hypocalcemia, because the calcium is precipitating out on the pancreas. So let's talk about that pancreas. Now, it normally is within the duodenum, lying next to the stomach, and the first part of the intestinal tract, the duodenum, within the intestines. And typically it's kind of a light pink color, and it's almost difficult to find in some animals just because it's kind of innocuous. It shouldn't stand out. So, a disease we see with the pancreas is the biggest one, diabetes mellitus. Cells need glucose as fuel, and through the process of glycolysis, the citric acid cycle, electron transport, and oxidative phosphorylation, glucose is chemically converted into energy in the form of adenosine triphosphate, or ATP, carbon dioxide, and water. So it's therefore important for the body to regulate the concentration of glucose in circulation. Levels must be kept within certain limits to assure that adequate fuel is always available for energy production. The endocrine pancreas aids in this regulation. Beta cells in the pancreatic islets or islets of Langerhans produce the hormone insulin, which facilitates the entry of glucose into the cell for the process of glycolysis. Diabetes mellitus results when these beta cells stop producing insulin in adequate amounts or when the cells in specific body tissues become resistant to the action of insulin. They say, nope, thanks, insulin. I don't want your help. I don't want this glucose in my cells to produce energy. That can be a problem. The incidence of diabetes mellitus in the dog and cat is reported to be between 1 in 100 and 1 in 500, so it's pretty common. Cause of the disease is unknown, but we think that chronic pancreatitis, where the pancreas gets inflamed over and over again, causing scarring of the pancreas and destruction of the normal pancreatic tissue, immune-mediated disease that attacks these cells, and then there may be hereditary predisposition. Those are all possible causes. Almost 100% of dogs and about 50% of cats will have insulin-dependent diabetes or type 1 at examination. As many as 50% of presenting cats will have non-insulin dependent diabetes or type 2, and that does not require insulin therapy. What it does require is a dietary change. And the therapy for diabetes mellitus in most animals includes this dietary regulation. We want to put them on a high fiber diet, high protein, low carbohydrate diet, much like diabetes mellitus in humans. And daily insulin replacement in 100% in dogs and 50% of the cats. In non-insulin dependent cats, drug therapy and diet restriction are somewhat successful in managing the disease. The type of insulin chosen for the therapy depends on the severity of the disease and animal needs. Treatment should be tailored to the species of the animal involved. Feline insulin most resembles beef insulin, and canine insulin resembles pork and human insulin. Although it would be ideal to match the structure of each species' insulin, it's not easy to do this. Because we are Americans and we eat a lot of beef and pork, it is actually fairly easy to produce beef and pork insulin. But their combinations have virtually disappeared from the market since late 1990s. So we have Vetsolin, which has taken their place as the most available insulin. There's also PZI, which is another insulin that's available for us as well. Animals with diabetes whose sugar concentration remains uncontrolled may become ketotic. The cells begin to use fat as fuel for energy production, yielding ketone bodies that accumulate in the blood. Acidosis, dehydration, and electrolyte imbalances can occur as a result of ketosis. So in normal non-ketotic diabetes, glucose levels aren't severely out of range for a long period of time. It happens to dogs between 4 to 14 years of age. Female dogs are twice as likely to be affected. Cats, all ages can be affected, with neutered male cats being most affected. Breeds predisposed to this disease are poodles, schnauzers, Keeshonds, Cairn Terriers, Dachshunds, Cocker Spaniels, and Beagles. We see polyuria polydipsia. That is the hallmark of the disease. Now, polyuria polydipsia you will find in a lot of diseases, especially endocrine diseases, but diabetes means increased or water loss, okay? And mellitus is a sweetness. So we may see weight loss, especially in cats. Polyphagia meaning they eat a lot. Sudden cataract formation, dehydration, and then in cats that have had this for some time, they get a plantigrade posture where they kind of slink in the back legs and they begin walking on their hocks. Ketotic diabetes will see all of the preceding symptoms I just mentioned, Plus, they'll just be really, really sick. Depression, weakness, tachypnea, increased rate of breathing, vomiting, and then an odor of acetone on the breath. So what is acetone? Acetone is a chemical typically used as a nail nail cleaning, nail polish remover. So if you can smell that, you can smell ketotic diabetes. The diagnosis, we're going to evaluate clinical signs present in the animal. We're going to observe for documented fasting blood glucose concentration greater than 200 mg per ml. But to be very honest, some animals produce, when they produce stress hormone or cortisol, that releases glucose into the blood. So occasionally in very stressed animals, we will see a blood glucose upwards of 250, 300. But if it stays at 300 in repeated tests, then we're going to suspect that we have diabetes. We can test the urine for glycosuria. So if we're seeing glucose in the urine, that's an indication spilling out from the blood. We can do a complete serum chemistry to rule out other concurrent diseases. Treatment, dietary management is the first thing. We're going to restrict the animal to a diet that is high in fiber and complex carbohydrates, such as prescription diet RD, Hill's prescription RD or WD. Fit and Trim is one that is similar at Purina. It's a little bit less expensive. It is not the first choice, or Science Diet Light. There are also very specific diabetic management diets that both Hills and Royal Canin and Purina produce that are for management of diabetes mellitus. So what this does is it helps to avoid a postprandial or after eating increase of glucose concentration and allows us a better regulation of blood glucose concentration. Then we want to give insulin therapy. So 100% of dogs, 50% of cats are insulin dependent. We have two types of insulin that are available. We have Humulin, which is human, and then we have the beef pork combination, Iletin, which is less available, and then we have Vetselin and PZI. This disease will require lifelong insulin replacement therapy, and it must be administered by injection. Because it's a protein molecule, insulin can be damaged by heat, even rough handling, or chemicals. So we refrigerate the insulin bottle, we mix it gently by rolling it between our hands, and we avoid any syringes that may have been cleaned. So new syringes only, new needles only. The formation of cataracts is the most common complication that we see with animals with diabetes. It is irreversible once it occurs. If they want to have a surgical removal of the cataract and a replacement of the lens, that is possible but expensive. Consistent feeding and exercise routines will make regulation easier. So all of the things that we recommend that people do when they are diabetic, we can control with our animals much more easily. So we want to try to keep them on a very specific routine. Animals will require periodic monitoring of blood glucose concentration for the rest of their life. So they need to get ready, be able to handle some pricks and sticks. If we do not treat this disease, it will progress and may lead to death, and actually a lot of disease in between. Insulin shock is a problem when we have an insulin overdose. So if animals with diabetes receive insulin therapy that is too high to maintain the glucose at a certain level, and it removes all glucose from the body, or most of the glucose from the body, then we're going to have a major problem. So we try to avoid this with consistent feeding, both in the type and amount of food, exercise, and monitoring, so we can make insulin regulation easier for the owner and safer for the pet. Animals who experience fluctuations in diet, do not eat consistent amounts, or change foods frequently with a loss of appetite, or who are allowed to exercise to excess, can experience insulin shock. Exercise increases the need for glucose by body cells. So the more increased need uses up that exogenous insulin very quickly. Exogenous means the stuff that we are injecting, and it forces glucose into the cells rapidly and reduces blood concentration of glucose significantly. The rapid decline in glucose concentration in the blood results in a lack of glucose for the brain. We see symptoms of weakness, restlessness, incoordination, seizures, and coma. And these symptoms have been maybe seen in animals mistakenly given an excess dose of insulin. So, or if somebody gives the insulin and 2 hours later somebody says, oh, I forgot to give insulin, and gives insulin again. Or if the animal is eating or not eating or having diarrhea or vomiting and gets insulin. So we want to monitor this very, very closely. We want to follow a schedule. We want to feed them 20 to 30 minutes before we give the insulin, make sure that they're eating. We can measure urine or blood glucose concentration at the same time every day, so make sure that we're level throughout the day. And we base our insulin dose on the current blood glucose measurements, and we want our clients to be in contact with us so we can help them regulate that. So one of the recommendations is feed the animal 1/3 of its total daily diet with insulin administration, and feed the remainder of the diet about 8 hours later or at the time of the measured peak insulin activity. We're going to try to maintain this consistent daily exercise program, but avoid excessive exercise. If the animal is expected to be more active than normal, you want to give them a little bit less insulin that day. Owners should have a handy supply of sugar in the event of insulin shock, like Caro syrup, oral glucose solution or paste, some treats. They need to give those to the pets if there are any signs of insulin shock. Hyperglycemia, so too much glucose in the blood, is never acutely fatal, so they won't die suddenly. But hypoglycemia can be life-threatening very, very quickly. An insulinoma is a functional tumor of the beta cells of the pancreas, which secretes insulin or proinsulin, the molecule that makes insulin, independent of any negative feedback effect. So too much insulin in the body, what's that going to cause? Insulin shock. Hyperinsulinemia results in development of hypoglycemia. Prolonged or severe hypoglycemia will result in irreversible brain damage, weakness, ataxia, seizures, or complete collapse. Insulin-secreting tumors typically occur in middle-aged or older dogs. However, the disease has been reported in dogs as young as 3 years, and there appears to be a greater incidence of occurrence in certain breeds, like the standard poodle, German shepherd, Irish setter, boxer, and fox terrier. It is rare in cats, but it has been described in Siamese cat. The clinical signs are signs of insulin shock. So we see them intermittently or for short periods because the body will try to compensate for increasing blood glucose. Most signs will be exacerbated by exercise, fasting, or excitement. We'll see seizures, weakness, collapse, ataxia, bizarre behavior, depression, and lethargy. Diagnosis is through doing a CBC or urinalysis and blood chemistries just to rule out other diseases. Those should all be normal. But our blood glucose levels will be in the range of 15 to 78 milligrams per deciliter, so low. The ultrasound may detect a massive lesion in the pancreas, and that can help to confirm the suspicions. But what we are looking for is a demonstration of 3 symptoms, Whipple's triad. Symptoms occur after fasting or exercise. At the time of the symptoms, the blood glucose concentration are less than 50 milligrams per deciliter, and the symptoms are corrected by the administration of glucose. If we see those 3 things, we can be assured that we have an insulinoma. Surgical treatment can help. We can remove a single mass if there is one, or resect multiple sites. Sometimes we'll get kind of a cure or an improvement of the disease. Surgery may not be recommended for aged animals or animals that have many metastatic lesions, so it may not be worth it to put them through surgery. Medical treatment, if we have an acute hypoglycemic crisis, we need to give them Caro syrup or some type of glucose or sugar, something with sugar in it. Put it on their oral mucous membranes, and that will increase the blood glucose concentration quickly. If the animal responds to that, then they need to be fed a small high-protein meal and kept quiet until we can get them to a veterinarian. If the animal is in the hospital when the crisis occurs, so then we can give them an IV administration of 50% dextrose, which will alleviate the symptoms. And then we want to maintain them on diet and drug therapy. For chronic hypoglycemia, we want to reduce the frequency and severity of clinical signs and avoid acute hypoglycemic crisis. So by providing frequent feedings 3 to 6 times a day of a high protein, low fat food. We're going to limit their exercise to leash walking, and we can give them glucocorticoids. So we can use prednisone in this case to increase glucose being released into the blood. It antagonizes the effects of insulin at the cellular level, and so it's usually divided into daily doses. But if we see signs of hypercortisolism, so another endocrine disease, then we need to use an alternative therapy. Tell your clients that by the time most dogs are diagnosed with insulinoma, metastasis has occurred. So the cancer has already spread to the rest of the body. So the prognosis is poor. If we have proper medical management, we can keep them around for a year or two. So that's good. We want to limit exercise and excitement in animals with insulinoma, and we want to keep treats or sugar or food in our pockets anytime you're walking or exercising the dog. We want to feed them 3 to 6 times a day. We want to keep Caro syrup on hand for emergencies and teach them to rub the syrup on the oral mucous membranes for a quick glucose boost. Even with surgery, most dogs survive for less than a year. We want to avoid placing your hand or object into an animal's mouth during a seizure. So even if you have to put Caro syrup on the mucous membranes, sometimes it's difficult to do when they're having a seizure because you could get bit. Adrenal glands. The adrenal glands are located dorsally and cranially to the kidneys and are embedded in the perirenal fat, so the fat that surrounds the kidneys. They're composed of 2 distinct regions, which if you have already looked at my detail of the adrenal gland, you know what they are: medullary or central area and the cortical or outer area, each of which produces distinct hormones. The cortex has 3 families of hormones. Remember, we have different zones within the cortex: the glucocorticoids, the mineralocorticoids, and the androgenic hormones or sex hormones. Glucocorticoids promote gluconeogenesis, suppress inflammation, suppress the immune system, and inhibit cartilage growth and development. They are not essential for life, but they are important for maintaining normal homeostasis. Hyperadrenocorticism, also known as Cushing's syndrome, occurs when we have too many glucocorticoids produced by the adrenal gland. Glucocorticoids are also known as stress hormones. So here's a picture of where the adrenal glands are. Within the adrenal glands, we also have aldosterone. It's the principal mineralocorticoid, and it regulates electrolytes and has a potent effect on the water metabolism in the body because it's regulating mainly sodium, and wherever sodium goes, water likes to follow. Lack of this hormone is life-threatening. Hypoadrenocorticism, or Addison's disease, is seen primarily in the dog and rarely in the cat. Now, the androgenic hormones that are produced by the adrenal glands are identical to those produced by the testicle. The small amount produced limits their effect on the animal, so we don't see a lot of problems with androgenic hormones related to disease of the adrenal glands. The medullary area produces 2 hormones, epinephrine and norepinephrine. Both of these hormones affect the sympathetic nervous system and are involved in fight or flight response. The 2 most common diseases that involve the adrenal glands are Addison's disease, which is low aldosterone, and Cushing's syndrome, which is high corticosteroids. Hypoadrenocorticism, or Addison's disease, there's primary and secondary causes. Primary hypoadrenocorticism is most often classified as idiopathic, meaning we don't know what causes it. It involves atrophy of the adrenal cortex, which causes decreased production of both glucocorticoids and mineralocorticoids. Now, remember, glucocorticoids are not needed for life processes, but mineralocorticoids are. When we have loss of aldosterone, it's responsible for most of the clinical signs that we see with Addison's disease. An immune mechanism has been suggested for this disease, so it's possible that there's something going on with the immune system which kills off the adrenal portion in which mineralocorticoids are made. The disease is not common in dogs. We don't see it a lot in dogs. I think we've seen it a little bit more frequently. It's even rarer in cats. Other causes of hypoadrenocorticism or secondary hypoadrenocorticism include trauma, fungal infection, neoplasm, and hereditary tendencies. Standard poodles and Labrador retrievers are more prone to this. So the clinical signs of Addison's. We see it more in middle-aged female dogs, usually less than 7 years of age. We'll see vague signs of depression. They kind of aren't doing right. Lethargy, weakness, anorexia, and weight loss. They'll be vomiting and diarrhea, polyuric, polydipsic. The symptoms may wax and wane over time, so they're feeling bad, and then they feel better, and then they feel bad, and then they feel better. We'll see bradycardia in about 1/3 of all animals and dehydration. Sometimes they'll come in and complete collapse as well. Diagnosis, what we're looking for is a ratio of sodium to potassium less than 27:1. Normal is between 27:1 and 40:1. So we're seeing an increase in the potassium versus the sodium. We verify the increased BUN, creatinine, and calcium levels. We check for decreased blood glucose and albumin concentrations, and we evaluate for acidosis, because those can be other ways that we will get these clinical signs. Adrenocorticotropic hormone stimulation test, or ACTH stimulation test, or STIM test. It provides the definitive diagnosis of hypoadrenocorticism. So what will happen is we will use either a synthetic or an actual ACTH, and we give it to the animal. And I've given you the doses here. It's not really important that you know what the doses are for any tests that I give you. You just need to understand that there are different doses, whether we're giving the ACTH gel or the synthetic ACTH. Animals with a hypoadrenocorticism typically have a low resting cortisol concentration, and it doesn't change after we give them ACTH. So remember, ACTH comes from the pituitary gland, and it comes because we have low levels of cortisol or mineralocorticoid, and it is supposed to stimulate the adrenal gland to increase the levels of cortisol and mineralocorticoid. If it is not doing that, that means that the adrenal gland is unable to produce more of it. And that tells us we have hypoadrenocorticism. Treatment. If we have an acute crisis, we give them normal saline, and it's preferred fluid for IV administration. We're trying to get more sodium into their body. Remember that aldosterone, that mineralocorticoid, it's responsible for retaining sodium, which retains water, meaning it's an antidiuretic. If we don't have that, then they're losing sodium like mad. We want to administer dexamethasone sodium phosphate or prednisolone sodium succinate. These are fast-acting corticosteroids. And then we can give them something called Percortin. It's desoxycorticosteroid pivalate. We can also give them fludrocortisone acetate. These are both steroids, mineralocorticoids that help to retain sodium like aldosterone should be doing. And that's typically the injection, the Percortin, is given every 28 to 30 days, whereas the Florinef is an oral medication that can be used daily. So when we manage them, not only are we giving this mineralocorticoid replacement, but we're also giving them some glucocorticoids. We try to give the lowest dose possible because it's really not necessary for life, but it is helpful, especially if they have a stressful event and use up all their glucocorticoids. Give them a little bit of a dose here and there. We want to monitor their electrolytes, their sodium and potassium. Remember, that's the first sign that we see that something's not going right. We want to measure their BUN and creatinine concentration, and we want to monitor their clinical signs. Clients need to know that lack of mineralocorticoids is life-threatening, but the prognosis is excellent with medical treatment, and we're going to need to do periodic serum chemistry reevaluation to make sure we're doing the right thing. Most animals, if they go through a time of stress, they're boarded, or they go to grooming, or they have a stressful event, we may need to give them glucocorticoid supplementation. So trauma, surgery, stressful situations, we want to know about that so we can provide some support. Hyperadrenocorticism. Now, this is the opposite of Addison's disease. So Addison's disease is hypo. Cushing's disease is hyper. It's rarely seen in the cat, but it is actually very common in the dog. It's applied to any disease state that results in hypersecretion of cortisol. Excessive secretion of cortisol may result from a pituitary lesion like excess ACTH or an adrenal tumor. So either a tumor in the brain or a tumor in the adrenal gland itself, which produces excess cortisol. Hyperadrenocorticism frequently can be the result of overmedication with corticosteroids, so we can cause it. We call that iatrogenic hyperadrenocorticism. That's a problem. Pituitary dependent disease, the brain tumor, is seen most commonly in dogs weighing less than 20 kilograms, so less than 10 pounds. So small dogs get the brain tumor. Breeds such as poodles, dachshunds, terriers, beagles, and German shepherds are most affected. Boston terriers and boxers have been reported to be at increased risk for development of this disease. Abnormal cells within the pituitary gland secrete excessive amounts of ACTH. So that stimulates or creates a hyperplasia of those adrenal glands because they're working really hard to do what the ACTH tells it to do, which is secrete cortisol. So we get an oversecretion of cortisol. This increased cortisol concentration usually serves to cause the pituitary to discontinue ACTH secretion, but the pituitary tissue is not responding normally. So now it's getting excessive amounts of cortisol and no response from the ACTH. The ACTH is still being pumped out. Functioning adrenal tumors secrete excessive amounts of cortisol independent of pituitary control. So if you have a tumor in the adrenal gland, it's like it's putting its fingers in its ears and going la 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 la. I can't hear you, because it just wants to produce more cortisol. Dogs with this form of the disease, the adrenal tumor, the abdominal tumor, are typically toy poodles, German shepherds, dachshunds, labs, terrier breeds. About 45 to 50% of them weigh more than 20 kilograms. So bigger animals have the abdominal tumor. Clinical signs of either type of Cushing's disease are the result of excess cortisol. They're usually slow to develop, so often go unnoticed by the owner. This is the poster child for Cushing's disease. It is a dog that's about 20 kilograms. What we see is bilateral symmetric alopecia. And do you remember the other disease that causes this? There's only one other endocrine disease that causes this, and that is hypothyroidism. And look at that rat tail. We also have this bowing or a bloating of the stomach. This is actually due to weaker muscles. We have weaker muscles throughout the body, and so we get a kind of a bloating of the stomach here. Clinical signs, we'll see it in dogs that are older than 6 years of age. 60 to 65% of them are female. They will be excessively PUPD and should be. They may not be, and if they're not, we won't treat it. But typically with Cushing's disease, they will be drinking a ton of water and peeing a lot. They'll be polyphagic, excessive panting, abdominal enlargement, sometimes obesity, muscle weakness, lethargy, lameness, bilateral symmetrical alopecia, pruritus, pyoderma, calcinosis cutis, or they're firm plaques that develop with calcium under the skin. Sometimes we see it, but it's kind of infrequent. Abnormal gonadal function, lack of estrus, soft, small testicles. Diagnosis is through increased alkaline phosphatase, increased ALT, which is a liver-specific enzyme, increased cholesterol level, increased blood glucose concentration, increased BUN concentration, and lipemia. So we see a lot of fat in the blood. We can do an early test called the urine cortisol creatinine ratio. And we take their urine, and if we have more cortisol than creatinine than is typical in the urine, then we know that we have screened for Cushing's disease, and it tells us, yes, we have Cushing's disease. That's great, but how do we know what kind of Cushing's disease we have? Is it a brain tumor or an abdominal tumor? We can do an ACTH stimulation test, just like we do for Addison's disease. I've described that in the Addison's disease section. In pituitary tumors, 80 to 85% that have the ACTH stimulation test, it will have an abnormal response. With the adrenal tumor, it'll look like a normal response. 20 to 40% of those may be normal. So sometimes it doesn't give us everything that we need. Hyperadrenic corticism may not be distinguishable from PDH in an adrenal tumor. So we don't always know if we can figure out, is it a brain tumor or an abdominal tumor? There is another test called a dexamethasone suppression test. There's a high dose dexamethasone suppression test and a low dose dexamethasone suppression test. Dexamethasone, it is a corticosteroid. So it is a a drug that we can give them and a medication we can give them that simulates what cortisol is doing in the body. So in a healthy animal, dexamethasone or corticosteroid will suppress the pituitary secretion of ACTH because of the negative feedback, which in turn will decrease cortisol concentration within 2 to 3 hours and keep them suppressed for 8 to 24 hours. So we need to do, when we do a dexamethasone suppression test, we need to get a baseline, give them injection, take a level in about 2 or 3 hours, take another level in about 8 hours. And so they stay with us for the day, but we get a pretty good idea of what's going on. With low-dose dexamethasone suppression, if with a pituitary tumor, there's no change in a cortisol concentration at 8 hours after injection. So they're producing the same amount of cortisol because they're not getting that negative feedback system. It's not affecting their pituitary. With the adrenal tumor, we have no change in any point of the cortisol concentration. So sometimes it's a better way, a dexamethasone suppression test is a better way for us to understand exactly what's going on. I have the procedure listed for you here. I am not going to read this to you, but it is available to you. Should you be doing this within your clinic, you can understand what you should be seeing. Treatment for hyperadrenocorticism. We can remove one or both adrenal glands. Obviously, if we have a pituitary problem, we may need to do brain surgery and remove part of the pituitary. And that can be really dangerous because that's going to be causing more problems throughout the body. Medical management, the most frequent treatment of choice is called OPDDD therapy, and it's also called Lysodren or Mitotane. What it does is it kills the zona fasciculata and zona reticularis. Remember those parts of the cortex of the adrenal gland. And so we will give them doses to actually actively kill those zones. It can also affect the zona glomerulosa and reduce aldosterone concentration, which produces Addison's disease. So again, if we over-medicate, we can cause the opposite disease or Addison's disease. Initially, what we do is 50 mg per kg per day divided into doses, and we give them after meals for about 8 days, and then we monitor their signs for a decrease in polyphagia and PUPD. We actually have the owners measure the amount of water that they are taking in. So we give this for a certain amount of days, then we repeat the ACTH stimulation test every 7 to 10 days until those cortisol concentrations are normal, and then we decrease the amount that we're giving because we don't want to kill everything. We just want to get it back to a normal level. Prednisone may be given during the loading dose regimen because we want to remember that we are drastically reducing those cortisol levels, and so we want to kind of keep that at a slow pace. Maintenance therapy, we will give them a dose of Mitotane or Lysodren every 7 days, so once a week. Some other drugs that we can use for Cushing's disease would be ketoconazole, given twice daily for 7 days, or L-Deprenyl. Ketoconazole is antifungal medication. L-Deprenyl is Anapril, something we also give for cognitive dysfunction syndrome or senility in dogs. So what we need to tell clients, this is a serious disease. Animals will require lifelong treatment. Periodic monitoring is required. Overdoses of Mitotane are common. We need to watch that very carefully. And if we do get an overdose, we're going to see clinical signs that are identical to those in Addison's disease. So if they see lethargy, weakness, vomiting, or diarrhea, we need to reduce the dose and get them in and treat them for Addison's disease. Prognosis. Average life expectancy after diagnosis is between 20 and 30 months with frequent recurrence of clinical symptoms. Okay, eclampsia. You may have heard this term used around pregnancy with humans. We also call this puerperal tetany. If you think of tetanus is lockjaw, or the rigid contraction of muscles. Puerperal tetany is secondary to hypocalcemia, and it occurs most commonly in the postpartum period, but it could also be seen in late gestation. It can be life-threatening. Predisposing factors include improper perinatal nutrition, heavy lactation, and inappropriate calcium supplementation. It's most commonly seen in the canine, not commonly seen in cats. Recognition of the clinical signs of eclampsia is important because therapy should begin immediately. The goal of treatment is to increase blood calcium levels with administration of IV infusions containing calcium. Prognosis can be good if the treatment is prompt, and we need to correct any of those nutritional deficiencies that that is causing the problem, or we want to diminish the lactational demands of the dam. So we may need to hand feed or wean the puppies early, or both, so that it reduces the amount of lactation that she's doing and the amount of calcium that's being dumped into her milk. Recurrence of eclampsia with subsequent pregnancies has been reported. So if you have a dam that you're using to breed and she has an a case of puerperal tetany, she could get it again. Clinical signs: they may be irritable, restless, salivate, facial pruritus, so itching of the skin, stiffness, ataxia, hyperthermia, so more hot because they've got contractions of those muscles, tachycardia, muscle tremors, and tonic-clonic contractions. Seizures as well. Treatment should not wait for laboratory confirmation of hypocalcemia. If they're pregnant or have just given birth, treat them for puerperal tetania. The total serum calcium levels, if you can get a blood sample quickly, will be less than 6.5 milligrams per deciliter. Treatment involves the slow intravenous infusion of 10% calcium gluconate solution. We have to monitor their heart rate and rhythm when we're administering these calcium solutions because we can actually stop the heart, and that's a problem. Diazepam is a Valium or a benzodiazepine. We may have to give that to control seizures. Oral supplementation of calcium should be started once we have controlled this immediate symptoms. We can use calcium carbonate tablets or capsules. Those are basic antacid capsules, or calcium gluconate, which is called neocalglucon syrup. And we want to improve the nutritional plane of the dam by feeding a balanced diet. For clients, we want to avoid excessive calcium supplementation during pregnancy. Why do we want to do that? We just said that they have low calcium in their blood. Why would we want to avoid it? Well, what we find out is that the body is not very good at maintaining calcium levels if they're getting too much calcium through the nutrition throughout pregnancy. What we want to do is give an appropriate amount of calcium in the third trimester of the pregnancy and while they are lactating. But we don't want to increase that too much beforehand. Development of signs in a pregnant animal is an emergency situation, and we want them to call the veterinarian immediately and get that dog in. The disease may reoccur with subsequent pregnancies, so owners should reconsider using animals that are predisposed to eclampsia for breeding. Hand feeding supplemental feeding of puppies may be required until the dam's calcium levels stabilize, and we may want to wean those animals early. That's it for endocrine diseases. I know that's a lot of information. We'll talk a little bit more about endocrine diseases within the classroom. Please bring your questions into me, and we will talk about them together.